Hey everyone, my name is Ryan Hay. Today we're going to discuss tuberculosis in the homeless adult population. So the objective is really to kind of discuss the homeless adult population in general, getting some statistics on them, and defining TB, its treatment pathways, some associated comorbidities, primary, secondary, and tertiary interventions associated with TB, management in the homeless population, and then some of the aspects associated with the screening tools and the secondary intervention phase that we can use. Population background, HUD, Housing and Urban Development, on the federal level did a study in 2016. They released kind of November 2016, toward the end of that year, that showed that on a given night in January across the country there are just over about 500,000 homeless patients, about 550,000 homeless patients on a single night. 22% were children, 78% were adults. Of that total number, 68% were sheltered. So really, you're looking at a number close to about 70% of homeless on a given night. And most recent data we have were sheltered homeless individuals, and of that large number, about 78 or so percent were adults. Interestingly enough, there are about 800,000 beds available nationwide the same night, so the beds don't necessarily match up to where the need is, or the individuals don't necessarily know that the beds are available, don't want to seek assistance through emergency shelters or things of that nature. But what's interesting is about half of those are permanent beds to be used for homeless treatment and care, which I thought was unique, and we'll touch back on that a little bit later on when we talk about some preventative measures. Tuberculosis background is a respiratory disease caused by the spread of M. tuberculosis droplets from human to human, cough, sneeze, basically interpersonal dialogue close at hand, where those respiratory droplets will get passed from one to another. Latent versus active, simply the difference is, active TB, you're actively symptomatic, you're signs and symptoms of the TB infection in the body, versus latent, which you have TB bacteria in you, but you're not necessarily actively giving that off or having those symptoms that would occur and cause you to be going through that disease process. About a quarter of the world's population has either latent or active TB, according to the CDC, so there's really a large number of people who are impacted by this. Diagnosis is pretty simple. 4 different tests: skin testing, TST, sputum smear, blood test, and chest X-ray. Initially, it can present as a fever, night sweats, weight loss. Can compound to get those respiratory symptoms that include cough, chest pain, hemoptysis. You're coughing up blood. I'm starting to get some more worrisome things that may trigger someone to go to the emergency department or seek treatment. And if they do, they may be a little bit later on in their disease process and may be a little bit more difficult to treat necessarily. Which is why we want to get that early screening, because there's early diagnostic tests done. We'll talk a little bit about more of the tests later on. TB in the homeless population. Homeless have about 3 times the emergency department diagnostic rate of TB than non-homeless. So it's definitely more prevalent in the homeless population than is the non-homeless. And some of those reasons are, when they do live in shelters or in closed quarters, they have that potential for an immunosuppressed system to begin with, because they have a greater instance of HIV/AIDS, as well as a greater instance of other bloodborne infections that may decrease their immune system's capability or ability to attack other disease processes, and they may be able to contract TB a little bit more readily, and then with that suppressed immune system, they're unable to adequately fight it off without getting some more complex medical complications associated with that. Also, interestingly enough, an higher instance of tobacco and alcohol abuse among the homeless population can also be linked to some issues associated with the compliance for medications, especially with alcohol abuse being linked to a negative outcome with the medications used to treat tuberculosis. So the TB meds won't work as well if you're abusing alcohol at the same time using alcohol. You're not going to have the intended result that you wanted, which could then obviously result in you not getting the treatment, or the homeless patient not getting the treatment that they need and not completing that course of therapy and decompensating because of it. So we're looking at about 1% of the U.S. population total suffers from homelessness or has, and about 5% of that homeless population reports having TB. So it is relatively prevalent. We talked about some of those immunosuppressive comorbidities. Medical compliance, again, they don't have necessarily physicians, they don't see the physicians, they can't pay for co-pays, they can't pay for medications. There's a lot of barriers to them getting the care they need. Treatment and follow compliance is difficult, especially in the transient population. And finally, the injectable drug use component of that puts them at a higher risk for some immunosuppressive disease processes, which then in turn, give them that higher risk of contracting and being pretty sick with a TB infection. Drug therapy is 6 to 9 months. It's an intense 2 months of multiple drugs being kind of used at the same time in varying schedules, followed by a continuous period of 4 to 7 months, still continuous use of prescription drug medication, but at a little bit more regular rate. There's about 10 FDA-approved drugs total. 4 of them I have listed there for you that are some of the more common ones that are used. But really, to get someone on this drug therapy and frequently seeing the physician for follow-up, seeing the care team for follow-up, you need to have good compliance. You need to have a good process in place for reaching out to them. We'll talk a little bit about that through the tertiary process. So look at primary prevention. Vaccines for tuberculosis are very limited in the United States. BCG is not recommended for use or necessarily for the entire population, nor is it really effective in adult populations. So we try not to focus as much on the vaccination component as we do the prevention component. And we talked a little bit about shelters. Working through environmental controls and personal hygiene are two of the biggest things. This is spread through droplet protocol. So people in close quarters sleeping near each other. One who potentially maybe have latent TB, may have active TB, and are in the same area, coughing on each other, sneezing on each other, sharing personal hygiene items. Just that kind of close interaction, especially in these permanent shelters that we have, could potentially cause a cluster of TB to kind of occur in this population. So what we want to look to do is educate the staff, educate the homeless patients that are in these areas on proper personal hygiene, proper cough etiquette, sneeze etiquette, make sure they have the supplies for personal hygiene to promote that in their areas. Secondary prevention, we look at snapshot surveillance, doing an annual kind of assessment of your defined population, trend the data, look at all the areas where the homeless could potentially be, and look to see if your interventions are having a positive impact or a negative impact. And some of those different secondary prevention screening methods we use would be the TST and the sputum. So these are relatively cheap tests. The skin test for the TST is very simple. A nurse can manage it. They can give it. They can read it. But it does lack some specificity, and it's not terribly definitive. Sometimes you may get a false positive that you would then need to rule out with chest x-ray anyway. Sputum, fast acting, however, again, similar problem. About 50% with TB will test negative for a sputum acid fast exam. So while it's logistically very simple, it's not terribly specific, so is it really worth the cost? And that's where we get into chest x-ray and radiography. Generally, it's more complex. It may cost a little bit more upfront, but it's very specific. You can easily accomplish it if you define the community ahead of time and if you work with the community and the homeless population in that area to get them the ease of access to chest x-rays and to a clinic to see somebody. You can kind of knock it out with one test instead of having to do the TST test and then having to come back, get that read, and then go through that whole process of, well, we may have to send you for a chest x-ray now. Knocking it off kind of at the beginning would definitely help. And then just some info here. You see about 10% increase in treatment of homeless population cause a 12.5% decrease in TB diagnosis 10 years later. So, an ounce of prevention now is really worth the amount of cure that it provides in the future. Tertiary prevention, what we look at is basically aggressive treatment. So that's that possibly for direct observation therapy, where you essentially trade treatment for a desired good or service. So in this case, you would be giving them treatment for tuberculosis in exchange for whether it be housing, a structured environment for them to live in, transportation, food, clothing, something that was a desired good of theirs. It's a good way to kind of barter with them to observe their treatment and therapy, make sure they're getting the aggressive treatments, make sure they're treating their comorbidities, that they're getting follow-up, that it's easier for them to do so, and at the same time, you're kind of helping them solve their tuberculosis problem. And again, this is mostly just a study discusses in '99. There was really a significant drop-off in active TB rate when they did this DOT for drug therapy, as well as some of the combined sputum, TST, and radiography testing. Finally, just focusing on homeless shelter staff, we don't necessarily define them as healthcare workers, but they're working in an environment similar to where the homeless are, where they're contracting TB, so you might want to consider screening them and surveilling them as well. And again, that's pretty much it on the front of homelessness with tuberculosis and some adult treatment pathways that we can use using primary and prevention techniques. Here are my references. Thank you.